dementia and delirium, and how dementia is actually not even a disease, and how dementia we heard about all the time, but it is kind of interchangeable with Alzheimer's, but they're totally two different things. Let's go over here. So delirium and dementia are both conditions where we have altered level of consciousness. So we're not able to make rational decisions. We don't have alert and orientation times 4. Basically, we can't answer 4 questions like who's your name, birthday, president, what's the date today, that kind of thing. We have a lot of questions and we're like, whoa, what the heck, bro? Crazy. So delirium is very brief, very short term. There's nothing wrong with the actual brain, okay? It's very quick, very short term. Basically, it means that you are overcome by, let's say, drugs, or you're inebriated by alcohol. You're post-op, you've had too much happy juice go into your lungs, and you have that sedation, and now you come out of your post-op situation swinging, not knowing where you're at. I've had patients punch at us. Or you can have a head injury that might make you a little bit disoriented. That's delirium, very short term. You can come out of it very quickly. Now, dementia is gradual. Dementia is long term. Usually it's caused by a tumor or chronic infections. Now, it's not a disease. It's a set of signs and symptoms, okay? Alzheimer's is a disease. Alzheimer's, they find plaque on the cells inside your brain. They diagnose it. Dementia is a set of signs and symptoms that have long-term, gradual, altered level of consciousness, okay? Same thing, delirium. Delirium happens to our older populations at night most of the time. That's what we call it, sundowner's disease. That's a sense, or that's a form of delirium. So with your elderly patients, your patients can act very violent at night. Same thing with your patients who are elderly with a urinary tract infection. So urinary tract infections can alter your state of mind, especially if you are elderly. So this is what's called delirium, very short term, short duration, all right? So what are the number one nursing interventions? They pretty much stay the same, guys. Number 1 is maintain safety. Keep those side rails up. Make sure your patient doesn't fall. That's huge. Your patients always want to be mobile when they have delirium or dementia. I can tell you so many stories of patients wanting to get out of their bed, thinking they're at home, and wanting to go upstairs or downstairs, and it's like, you're in the hospital. They don't understand this, okay? Number 2, maintain reality. Always reorient your patient. They're going to tell you, hey, my wife is upstairs. Or they're going to start calling out family members who have been deceased for a long time. Hey, my Uncle Sam is upstairs, or my Uncle Sam is in the basement. Let's go see him. And you're like, no, you're in the hospital, sir. Let's go back to bed. Over here, follow me. And you just kind of lead them that way. Number 3, avoid stating remember. Don't say that. Don't say remember you're in the hospital. Remember I told you this. Usually dementia or delirium patients can get aggravated easily. So if you want to fight, and if you want to be a little bit, what's it called? Have your guard up, state remember. But if you don't want to fight, and if you want to make your patient like you, just reorient him. It gets very redundant, trust me. When you have a 12-hour shift and you have to watch a guy trying to get out of bed, it's aggravating. But always reorient. So for pharmacology, we give them benzodiazepines, which help them reduce anxiety, helps them also to go to sleep. These are our PAM and LAM drugs like lorazepam, also fancy words for Ativan. Antipsychotics, we give Geodon or Haldol. That usually is the last line drug. We'll try the benzos first, okay? What are we looking for as a result with our nursing process? 0 injuries. We don't want our patient to fall down and crack their skull open. That's bad. We want to maintain the weight, especially with our dementia patients, because our dementia patients usually do not make time for eating. They're usually trying to find something. They want to go somewhere. That's why we always have to reorient them, redirect them. So scheduling and making sure they eat is a big priority. That's why maintaining weight is a very good result, or basically response. It's a very good patient goal. Social interaction appropriately. Usually, our dementia patients will want to be by themselves because they're trying to usually solve cases. They want to find something somewhere. So, including them in group activities, making them social again, not so resistant. That's one of the main goals. So, just remember, dementia, delirium, 2 totally separate things. Dementia long-term, delirium short-term, and these 2 are not diseases. They're just something, a set of signs and symptoms that happen. Alzheimer's, that's a disease. Plaque on your brain, okay? So let's go into the next video here.